Excellent. So thank you all for joining us at this early hour. We are discussing hyperkalemia, which may seem like a bland topic, but trust me, with this panel, it's going to be the most exciting start to your day. And so my name is Muthiah Vaduganathan. I'll be the chair of this session. I'm really privileged to be joined by this multidisciplinary panel, including Drs. Albert, Desai, and Page. I'd like to thank AstraZeneca for providing an educational grant to support this program, as well as Vox Media for sponsoring the symposium. Please complete the pre-questionnaire, which is being collected right now by our personnel. And to receive credits, please complete the evaluation form on your seats and return to the staff before the end of the meeting. You'll see our disclosure information in the pamphlet, along with select slides that are representative of the talks. The presentations in full will be available on cmeplanet.com. There will be question cards that will also be passed out. We'll have plenty of time at the end to ask questions, because ultimately, hyperkalemia is an issue of clinical care and nuance, and so we'd love to kind of help navigate those issues. And to be made aware of future programming, certainly follow the sponsor on @CME Planet on Twitter or other social media, and as per usual, turn off any loud electronic devices or put them to silent. So we're going to get started. First, Dr. Desai is going to set the stage about the importance of hyperkalemia in clinical practice, especially its impact on RAS inhibitor therapy. I'll introduce potassium-lowering therapies, and then Dr. Page will bring us home with a case that will ground us, and we'll be joined by Dr. Albert for expert opinion and expert input. So, Dr. Desai, the floor is all yours.
All right, well, welcome to another beautiful day in Amelia Island, and what better way to start than with a discussion about hyperkalemia. So I have these disclosures, which are indirectly relevant, I think, to some of the discussion about potassium binder use. There are really 4 goals for this next 15 minutes. I want to remind you that treatment with RAS inhibitors, as we all know, is a cornerstone of therapy of patients with heart failure, particularly with reduced ejection fraction, but now with the role of aldosterone antagonists really across the spectrum of ejection fraction, but it does increase the risk of hyperkalemia. Hyperkalemia, and particularly the fear of developing hyperkalemia, is a major driver of underuse and underdosing of RAS inhibitors in heart failure. Dose reduction or discontinuation of RAS inhibitors is associated with worse outcomes in heart failure, and there are strategies short of potassium binders that we can consider to mitigate hyperkalemia risk. I think I'm going to start from what you already know, which is that comprehensive RAS inhibitor-based medical therapy is a powerful strategy for extending life and reducing morbidity in patients with heart failure. And I love this slide, which is kind of from Jasper Trump, which really documents or chronicles this sequence of guideline-directed medical therapy evolution and what it has meant for impact on mortality in our patients. And you'll see that compared with placebo at the bottom of the slide, we've moved the needle steadily to the left, and 4-drug medical therapy addressing 5 mechanisms now reduces mortality compared with an imputed placebo of about 60%. And we now understand that 4 pillars gird our therapy for patients with heart failure, 2 of which are RAS-active therapies, and these therapies are being expanded to patients with slightly higher ejection fraction in the mildly reduced group, where we think the treatment response is likely to be quite similar. The other message within the guidelines is that it's not enough to initiate therapies. We need to titrate the therapies to the target doses, and that's based on this data that particularly for RAS inhibitors like ACE inhibitors and ARBs, that higher doses of drugs are associated with better clinical outcomes. We don't have necessarily the same data for ARNIs, but we presume the same to be true. And so the guidance is to start the medicines and then dose titrate them to the highest dose that is achievable. And what we know that is that in clinical practice, although we understand the imperative to do this, we don't routinely do it very often. And this is data across a number of registries talking about the different categories of drugs in our core arsenal. And it looks like in these studies that a large number of eligible patients are not adequately treated with particularly mineralocorticoid receptor antagonists. Only 1 in 3 patients who are eligible are treated. And usage of RAS inhibitors is better, but still not optimal. You'd expect these numbers to be upwards of 95% in most people, because this is patients without contraindications. And when we look at dose of agents, the data is even more bleak, because the red pie slices reflect the number of patients who are either on no medication or at subtarget doses. And you can see that across the spectrum, patients generally are underdosed on RAS inhibitors throughout the spectrum. And so there is work to do, and this is why a large portion of our effort of late has focused on implementation strategies aided by multidisciplinary teams to improve our implementation and secure some of those outcomes that we showed you. Now, I think one of the things we should focus on a little bit during this session is really where is the potassium truly abnormal? And this is where our labs tend to tell us that the thresholds for a target range of potassium should be. We'd say that anything above 5 is somewhat abnormal, and we tend to call it hyperkalemia in trials, particularly when it exceeds 5.5 or 6, the serum potassium. And then on the low end of the spectrum, typically it's said that the potassium is low, there's hypokalemia when the K is less than 3.5, but that's a wide range in between of normal. And I think we're starting to refine our understanding now of where the truly normal potassium or the target potassium should be in patients with heart failure. There is a U-shaped or J-shaped relationship of potassium with mortality. And that means that there's risk not just at the high end of the spectrum, but at both ends of the spectrum. So it's important to attend the risk of hyperkalemia, but we should also be mindful that low potassium is a problem in many of our patients with heart failure. And you can see that as you accumulate risk factors for hyperkalemia, like heart failure or diabetes, this curve shifts upward at both ends, so that there is heightened risk for both hypo and hyperkalemia in those patients. And many of our patients do have this amalgamation of risk for hyperkalemia, including heart failure, CKD, and diabetes. I think this trial is particularly interesting, the podcast trial that really sought to examine in 1,200 patients with an implanted defibrillator and a potassium less than 4.3, what is the impact of a strategy of intensifying the potassium target to a level between 4.5 and 5 versus usual care. And in that high normal potassium group, at the end of the study, there were actually fewer events of the composite outcome of sustained VT, appropriate ICD therapy, unplanned hospitalization for heart failure, arrhythmia, or death from any cause than in the standard care group. The achieved potassium in that group was around 4.3 millimoles per liter, compared to a level less than 4 in the other group. And there weren't an excess of hospitalizations for hyperkalemia in that higher target group. Most of these patients had heart failure, the vast majority, and about half had reduced EF. And so what this means is that perhaps we need to revise our thinking about what's an acceptable potassium. We usually said above 3.5, but perhaps it should be more in the mid-4s that we're trying to achieve in order to prevent problems with hypokalemia, although our focus has always been on that high end. So if we're thinking about strategies to mitigate hyperkalemia risk, we should understand something about how potassium is distributed in the body and how it's regulated. Most of the potassium in our body is within the cells. And there is equilibrium or shift between the intracellular compartment and the plasma that is governed by a number of factors, including insulin, beta receptor stimulation, the blood pH. And then the balance of serum potassium is maintained by the balance between our dietary intake and renal excretion. Most potassium is excreted in the kidney, a small amount in the stool. And this is why really kidney dysfunction is such a heightened risk for hyperkalemia, and actually dyskalemia of all causes. And hyperkalemia in patients with normal renal function is pretty uncommon because the kidney is pretty efficient at excreting potassium. So how does the kidney do this? Well, about 75% of the potassium is reabsorbed in the proximal tubule, and then there's variable secretion through aldosterone-sensitive channels in the distal tubule and the collecting duct. And this is, because this is an aldosterone-sensitive process, inhibition of aldosterone or aldosterone dysregulation creates heightened risk for hyperkalemia, as does heart failure or comorbid CKD, which tend to impair some of these renal maintenance functions. And then treatment with RAS inhibitors impacts this because it blocks renin-angiotensin system inhibitors impair at various levels the function of angiotensin II and aldosterone, which are important regulators of potassium balance in the kidney. And we also know that beta blockers are also RAS inhibitors, so they may exacerbate this risk. And then other drugs in this pathway, including novel aldosterone synthase inhibitors, probably also impact this. And so when we give these drugs in combination, there is a conspiracy that augments the risk of hyperkalemia. And we know that from all of our trials that the combination of RAS antagonists is associated with higher risk for hyperkalemia than any of these drugs alone. And so heart failure, particularly in patients with CKD who are treated with RAS inhibitors, it's a setup for the development of hyperkalemia. And this is one of the reasons that the guidelines really encourage us to monitor potassium very carefully when we initiate the drugs and during longitudinal care. I think the other thing, the biggest sort of focus when we think about hyperkalemia tends to be on use of mineralocorticoid receptor antagonists. And that's largely driven by this very familiar report in the New England Journal several years ago after the publication of the RAASi trial that hospitalizations and death related to hyperkalemia went up because of more widespread utilization of mineralocorticoid receptor antagonists. And I think this sticks in our psyche and makes us very worried that every time we start an MRA, our patients are going to develop life-threatening hyperkalemia. And there is an association between use of MRAs and hyperkalemia. Here's data with steroidal MRAs. The same can be true, although at a lesser extent with, this is non-steroidal MRAs. The same might be true of steroidal MRAs, although perhaps to a slightly lesser extent. And you can see there's a relationship not only between the use of MRAs and risk, with higher risk in those with CKD, but also a relationship with dose of MRAs. And in our trials, therefore, all the patients who have been treated with mineralocorticoid receptor antagonists do experience higher rates of hyperkalemia, whether they have low or high ejection fraction, and also slightly lower risk for hypokalemia. The one thing that is important to remember, though, is that despite the heightened risk for hyperkalemia, the benefits of MRAs, particularly in patients with low ejection fraction, are preserved really across the spectrum of potassium. And so it means that regardless of that risk, there is treatment benefit, and we need to make sure that we are trying to test the ability to tolerate these agents before we abandon them. And fear of hyperkalemia alone shouldn't be a reason not to use these drugs. So what do we do when the potassium goes up? Well, I think what happens in clinical practice is very quickly we tend to stop the drugs, or we dose reduce the drugs, because the immediate assumption is that the drugs are what are responsible. And what seems to be the case when we look at these large registries, this is a managed care registry in clinical practice, is that the threshold at which clinicians tend to intervene to reduce these life-saving drugs is pretty low. I told you before that high potassium, really even our most conservative definition, is around 5.5 or greater. But you can see here that even when there's mild hyperkalemia between 5.1 and 5.4, just outside of that range, many people do intervene to interrupt the drugs. The orange and gray bars reflect either down titration or discontinuation. And almost half patients in that mildly elevated range seem to lose the RAS inhibitor in clinical practice, and even more when the potassium goes up higher, where many of us would feel less comfortable. And the guidelines tell us we shouldn't stop the drugs until it's more than 5.5 or even more than 6 in these patients. I think most of us would be heightened concerned as the number gets closer to 6, but I think below 5.5 is probably acceptable. And it also seems to be the case that MRAs, more than RAS inhibitors, are really the vulnerable component of the regimen. And in most cases, clinicians seem to reach to stop the MRA or dose reduce the MRA in the SCREAM registry rather than the RAS inhibitor, particularly if patients have more significant hyperkalemia. And the problem with discontinuation is that rechallenge is pretty uncommon, right? Once it's stopped, there's a note in the chart or sometimes in the allergy list that says the patient can't tolerate mineralocorticoid receptor antagonists due to hyperkalemia. There's often no comment about how severe that event was. And then most of us are loath to restart it, particularly if we weren't around when the drug was stopped to begin with. And so the patient is permanently discontinued and deprived of the potential treatment benefit. So what happens when we stop RAS inhibitors or MRAs in patients with heart failure? Well, I think we have some data, largely from registries, no randomized long-term withdrawal trials. But you can see here a distribution of the different RAS inhibitors in this large registry from Optum. And then what happened when hyperkalemia happened in patients with heart failure in stage 3 or 4 CKD who were on at least one of these agents and experienced an episode of hyperkalemia. And you can see that in general, about a third of patients had the drug stopped, about 8 to 10% of patients, regardless of class, had the drug down titrated, and the balance had the drug maintained or up titrated. And if you look at the right curve, or the right panel, you'll see that the green curve, which reflects those in which the dose was maintained or up titrated, is far better outcome than those in the orange or yellow curves, which are the curves reflecting dose discontinuation or dose reduction. Almost a 50% or 50-fold higher, a 50% higher risk of the composite cardiovascular outcome in those who come off drug. Now, this is observational data, and so it's potentially confounded, but it still makes the point that coming off these drugs is a signal of risk for our patients, and we should think carefully about that. The same is true for MRA discontinuation in the registry population from Sweden. The risk of death, MI, stroke, or worsening heart failure is much higher in patients who come off the drugs than in those who stay on the drugs, although the risk of recurrent hyperkalemia does go down. So what can we do to mitigate our hyperkalemia risk? Well, I think the one thing to think about are strategies for sequencing drugs, and we have data that the way in which we introduce medicines, particularly to the low EF heart failure regimen, may mitigate the risk of hyperkalemia. And here's data that we contributed from Paradigm HF, looking at patients who were treated with an MRA or baseline, then initiated on sacubitril valsartan versus enalapril. And you can see that the risk of hyperkalemia in MRA-treated patients is lower in those treated with sacubitril valsartan than with enalapril. So this means that use of ARNI may mitigate the risk of hyperkalemia with MRAs. And so sometimes this may be one strategy to do this. And then another is to give SGLT2 inhibitors, perhaps before or concurrent with the MRA. And we have data both from Emperor Pooled and DAPA-HF that the risk of hyperkalemia is lower in patients who are SGLT2 inhibitor treated. And so there may be an insight here about sequencing in patients in whom you're worried. Maybe get the SGLT2 inhibitor and ARNI on board and then add the MRA to mitigate that risk. And then there are a number of clinical strategies that we all use to prevent hyperkalemia and heart failure beyond potassium binders. We can discontinue concomitant medications that impair potassium excretion, so use of nonsteroidal anti-inflammatory drugs. Some of our patients take herbal preparations that may contain potassium. Salt substitutes often are very rich in potassium, and sometimes patients use that, coconut water, other things. Dietary potassium is an important contributor here. You should take caution with use of RAS antagonists in the highest risk groups and monitor those patients more carefully. And then remember that use of loop diuretics will lower serum potassium levels in patients who are congested and may be a strategy to help attenuate that hyperkalemia risk. I mentioned the sequencing issue, which I think is an under-discussed opportunity. And then we always need to monitor potassium, but be mindful that mild elevations in potassium shouldn't always lead to drug discontinuation or interruption. So I'll close with the same messages I started with, which are really that treatment with RAS inhibitors is critically important because it improves outcomes and longevity in our patients. Hyperkalemia is a major driver of underuse and underdosing of RAS inhibitors, but if you reduce the dose or stop the drugs, outcomes do get worse. And so think about optimal sequencing and strategies for prevention when you start these agents. And then I think I'll hand it to Dr. Vaduganathan to walk us through what other strategies are available.
That was fantastic. Thank you so much, Dr. Desai. And before I get started with potassium binders, I'd like to just begin with some ground truths that I believe in, that I share. And the first is, why are we talking about a single electrolyte when we're talking about a complex entity like heart failure? And the truth is that that single electrolyte, hyperkalemia or potassium, is the major limiting factor of most guideline-directed medical therapies in clinical practice today, at least in the United States and in Western Europe. And so while it is a single point in this entire very complex axis of heart failure, I think it is important to discuss. The second ground truth is that we're having an increasing armamentarium of guideline-directed medical therapies or medical therapies for heart failure that also affect potassium levels. So this extends these learnings extend well beyond MRAs alone to a much broader set of therapies. And then finally, we can borrow from guidance and clinical care from other entities. There are many, many instances in medicine in which we use a facilitating medicine to incorporate a medicine that has life-saving or disease-modifying potential. For instance, we use PPIs commonly with dual antiplatelet therapy after an acute coronary syndrome. We may use bone protective medicines to facilitate steroid use in patients who require them for various conditions. We use various therapies to prophylax against some of the risks of chemotherapy. And so in a condition like heart failure that has grave risks, using an additional agent, while maybe unsavory at times, may be necessary to facilitate necessary therapy. So when we do receive that page for a potassium level of 5.4, 5.6, 6.1, there are many, many strategies that we might undertake. And our gut reaction, and I think every one of us, our default is, well, let's stop the drug that might be offending and causing hyperkalemia, and then reassess, and then we'll re-strategize. And that's okay. And that is a familiar and common strategy and might be necessary at times, especially when potassium is extremely perturbed. However, Akshay has already discussed some of the, especially when potassium is only modestly elevated, some of the more conservative measures. And the single strategy that will limit treatment discontinuation is retest the potassium. Ask the patient to come back even the day after or in 2 days and recheck the potassium. And in most clinical studies, 50% of hyperkalemia is no longer present on retesting. The other strategies are vitally important: concomitant medication adjustments, as well as dietary changes. Dietary potassium in this breakfast session is a major contributor to hyperkalemia. So those conservative strategies should still be 1, 2, and 3. There are going to be circumstances where potassium recurrently increases, and so as such, those conservative strategies may be limited. And as such, those are the individuals, especially who are at heightened risk for recurrent hyperkalemia, who sit at the intersections of heart failure, kidney disease, for instance, where we might be thinking about adding a potassium binder. So there are especially 2 potassium binders that have been well studied in heart failure, and I'll take you through some of that evidence. And both of these have been shown to help facilitate ongoing use of medical therapies such as MRAs. So that is Pertermer and SCZ. So the first that I'll take you through is Pertermer. This is a nonspecific cation binding that occurs in the gut. It primarily occurs in the distal colon. It acts fairly rapidly, within 4 to 7 hours, and its efficacy is maintained out to a year. So remember that at least our initial learnings of potassium-lowering agents has always been one of reaction. We remember in our medical school days or our residency days or in-hospital days that we use potassium-lowering agents in the acute setting. When the potassium is extremely high, we rapidly give a potassium-lowering agent, especially historical potassium-lowering agents, to rapidly bring down the potassium, and then the patient is discharged from the hospital off any other therapy. Now, this is reframing to a more proactive approach where we can use therapies to actually facilitate long-term use of guideline-directed medical therapies, where you're using actually daily dosing or continued chronic dosing of these therapies to actually facilitate dosing. Importantly, these medicines do have some drug-drug interactions, so if you are going to dose them, we do recommend separating other oral agents by at least 3 hours. And there's some adverse events which I'll take you through. So the key study was the DIAMOND study. Both the studies I'll share have a very similar design because it's trying to target the patients that get into trouble. And so it tried to prove that hypothesis by first identifying individuals who were either hyperkalemic at baseline, they had potassium levels above 5, and they're already on medical therapies like RAS inhibitors. Or they were normal kalemic, their serum potassium levels were between 4 and 5, but they had a history of hyperkalemia that actually led to treatment discontinuation. So these are the patient profiles that we're going to think about in the cases to follow in our discussion of potential use for these agents. So the trial then initiated Patermer and concomitantly optimized RAS inhibitor therapy. So optimized ACE inhibitor ARB-ARNI, optimized MRA therapy. Subsequently, patients were randomized to either withdrawal of Patermer or continuation of Patermer, trying to isolate what is Patermer actually doing in these patients. So the primary results were that Patermer reduced the risks of hyperkalemia above 5.5. So in that withdrawal phase, you had a rise in potassium, including crossing these thresholds of 5.5 and 6 in the placebo arm. Furthermore, patients in the continuation arm of the potassium-lowering therapy with Patermer had ongoing ability to reach target dosing with MRAs to a greater extent than with placebo, and this extended out to a year after therapy. Now, in terms of safety, this was a well-tolerated therapy. You can see overall adverse events were similar between arms. Overall serious adverse events were relatively similar between arms. As would be expected, hypokalemia was slightly greater with the potassium-lowering agent, but importantly, this is mild hypokalemia. We're not drastically lowering potassium levels such that people are becoming markedly hypokalemic. Furthermore, there are some GI-based side effects that also were classified as mild. So SCZ is the second agent I'll discuss. Again, very similar in terms of gut binding, preferentially, though, in this case, is potassium exchange with sodium and hydrogen. It acts throughout the GI tract. It acts very rapidly with actions as early as 1 hour after initiation. Again, this is intended for chronic use, and while it has indications for acute management as well, there is maintenance dosing that is intended here. There are limited effects on other orally bioavailable agents. However, again, the labeling does recommend some spacing with other oral agents by 2 hours. And I'll take you through the adverse events again. So RAASi, again, very similar design in that it's trying to target the patient profiles that we think might benefit from a potassium-lowering agent. This is a super high-risk cohort, so heart failure with reduced EF. They're on optimal medical therapy, but they're not treated with an MRA, and they either have already present hyperkalemia, so prevalent hyperkalemia, or they were judged as very high risk for hyperkalemia. And so the cohort 1 is those who already have potassium elevation. Their potassiums are between 5 and 6, and in those individuals, SCC was started, attempted to normalize serum potassium, and at that point, you initiated the MRA, which was, in this case, spironolactone. In cohort 2, they were already normal kalemic, and so you started spironolactone, and if the potassium rose above 5, then you started SCC. And again, you then randomized individuals to either continuation of SCC and spironolactone to guide that facilitating approach, or withdrawal with just spironolactone alone. So here is sort of a pathway of that open label run-in. So what happens if you, let's take that left-hand column first. These are individuals who start out already with high potassium levels. You start SCZ, and 80% are able to actually achieve normal kalemia in these people who already have prevalent hyperkalemia. And then once you actually titrate the MRA, about 77% are able to reach not just low doses of Spiro, but this is 50 milligrams of spironolactone once daily and still maintain normal kalemia. Same is true in this other pathway, which is individuals who are at high risk for hyperkalemia but are otherwise normal kalemic. In this case, these high-risk patients, again, use of the MRA, many patients redeveloped hyperkalemia or developed hyperkalemia as would be predicted, but SCZ normalized the potassium and again facilitated long-term use of spironolactone. So the primary endpoint was a multifold increase in the ability to achieve this sort of holy grail, that is, using spironolactone at a reasonable dose, 25 or 50 milligrams, maintaining normal kalemia, 3.5 to 5, and not requiring rescue therapies, that's urgent attention for hyperkalemia. And there were a number of confirmatory endpoints. Again, this is reductions in, for instance, need for rescue therapy, hyperkalemia episodes, requirement for treatment discontinuation or down titration. So this in general was quite favorable. There was no difference in KCCQ, and both of these studies weren't powered for clinical events, and so that might be something to discuss. A lot of the data that has been generated with potassium-lowering agents is to facilitate therapies that we know are beneficial to lower risk, not necessarily to lower risk in themselves. So they're facilitating agents, not risk-lowering agents in themselves. The AE profile was also well tolerated. You can see overall AEs and serious adverse events were similar between arms. Patients were able to remain on therapy without discontinuation of therapy due to an AE to a similar extent between SCZ and placebo. The key adverse event to be noted, because one of the components of SCZ is sodium, there is sodium retention in some individuals, and there's higher risks of peripheral edema. And so think about sort of mild peripheral edema, very similar to calcium channel blocker, amlodipine type effects, or TZD type effects, or that we commonly see with other therapies. And there was a slight imbalance here of cardiac failure, serious adverse events, and again, we can discuss this. This trial wasn't powered for clinical events, but this was observed in the adverse event profile. So to conclude, the risk of hyperkalemia, whether real or perceived, unfortunately is a major barrier, and so it's important to discuss this up front and be transparent in our discussions with fellow clinicians, but also with patients and caregivers. With contemporary tools, conservative measures, as well as concomitant adjustments and medications often may be able to manage especially modest levels of hyperkalemia. In cases of recurrent hyperkalemia, we should shift from this reactive approach that you receive a page and then what do I do next, to a proactive approach where we can actually facilitate ongoing use and avoid this moving forward. And the availability of these potassium-lowering agents now instills new confidence in our ability to actually manage potassium alongside up-titration and maintenance of medical therapies, which we know are beneficial for our patients. So thank you very much, and I'm going to turn it over to Dr. Page now, who will bring us to a case. So thank
Wonderful.
you.
Thank you so very much, and I promise I won't call spironolactone the hoe of GDMT this time. We've had several debates on this. Nonetheless, it's a pleasure to see everyone. It's always an honor to be here with such a distinguished panel, as well as everybody. It's so great to see friends and family here. All righty, so let's just talk a little bit about a case. Now, don't throw stones at the presenter. All right, now, nonetheless, my name is Robert Page. I'm a clinical pharmacist from the University of Colorado. I have no disclosures. All right, so really what I'd like just to highlight here with this case is just to recognize hyperkalemia as, again, a frequent, treatable, manageable side effect. We'll explain some of the relationships between down titration and discontinuation, but also we'll talk about just some of the best practices that have been out there. But more importantly, I really want to I have experts up here who sit on guidelines and this, that, and the other, and I am going to pick their brains while I'm up here. So, first of all, we have a female patient. She's in her 50s. She presents to the ED with symptoms indicating acute heart failure. She's decompensated. She's got shortness of breath on exertion. She's got lower extremity edema and fatigue. She's got a past medical history of HFrEF. So she's got a left ventricular ejection fraction of 35%, New York Heart Association functional class 3 and stage C. You know, her baseline's been running EGFR around 31. She's been previously hospitalized for acute decompensated heart failure, and these are the meds that she's on. She's on sacubitril valsartan, and again, taking note of the dose, 4951, carvedilol, 12.5, spironolactone, 25, furosemide, 40, and dapagliflozin, 10 milligrams, once daily by her cardiologist. So on presentation, her initial EGFR actually is 18. She's got a serum potassium of 5. She's got a systolic blood pressure of 100 and a heartbeat of 55. Okay, her EKG was unchanged from the previous record. She didn't have any evidence of ischemia or arrhythmia, and she revealed that she frequently does consume foods that have a high sodium content. She also admitted, she was admitted for further treatment. Okay, I do want to highlight, you know, one of the things I do as a clinical pharmacist is, you know, what is their insurance, what is their formulary, what's covered, and in particularly this patient has Medicaid from an expansion state, so it's actually excellent in terms of her primary insurance coverage. All right, so I don't have, we're not doing ARS, so we're going back to kindergarten, so we're going to raise our hands, all right, and if you don't raise your hand, I'm going to call on you. So, what recommendations would you make regarding this patient's cardio-kidney drug regimen? All right, is it A, stop the valsartan and spironolactone and start hydralazine isosorbide dinitrate? B, stop spironolactone and dapagliflozin and increase the sacubitril valsartan? C, continue current medical regimen and start an IV loop diuretic? D, continue current regimen and add a potassium binder? I'm just going to get a raise of hands. A, B, C, okay, D. All right, so a few hands out there. All righty. Is there an E? None of the above? Yeah. No, that's what the panel's going to discuss. Okay. All right. So with that being said, and again, this person didn't have a clinical pharmacist on their team. But anyway, the team discontinues the patient's spironolactone and the dapagliflozin. And I will tell you, that's the gut thing that most of our internal medicine residents on surface, they'd go, they would stop it due to the low EGFR on hospital admission. The carvedilol was continued, and the sacubitril valsartan doses were actually increased, okay, to 90, 97, 103 twice a day. Intravenous loop diuretics are prescribed to reduce fluid overload, and then again, labs were repeated. And again, this is the day 2. From days 3 to 4, say over these 3 to 4 days, the patient had some symptomatic relief with their IV diuresis. They had some improvement in their edema, some functional status, ambulation without dyspnea on exertion. By day 4, the kidney function had improved up to about 30, all right? And her IV diuretic regimen is converted from IV to PO. Right? Dapagliflozin is added back to the regimen. However, her potassium rises, and it rises up to 5.6. But there are no EKG changes, and her systolic blood pressure is still around 90, with a heart rate of 56. So here's her current regimen. Right, so she's on sacubitril valsartan 97, 103 twice a day, carvedilol 12.5 twice daily. She's on just 60 of furosemide in the morning, and then dapagliflozin 10 milligrams daily. All righty, let's turn back to our audience. What recommendations would you make regarding this regimen? Would you, or the patient's medical regimen, would you A, discontinue the valsartan, or excuse me, the Entresto, and add hydralazine isosorbide dinitrate? Would you B, continue the regimen but add metolazones for dual nephron blockade? C, discontinue Entresto but add a potassium binder prior to discharge? Or would you restart all RAAS inhibitors and add a potassium binder prior to discharge? All right, so let's see if everyone's interacting here. How many want to do A, B, C, D. All right. All right, well, the team decided, okay, to stop the sacubitril valsartan, all right? Serum potassium was 5, you know. That was achieved by day 5. And the patient is discharged on the following, all right? Carvedilol, furosemide, or carvedilol 12.5, furosemide 60, dapagliflozin 10 once daily, okay? So, and again, I think the discussion, particularly with this case, was, well, we want to make this, you know, we don't want to have polypharmacy. We want to make sure make sure it's less complex regimen. Patient went home. So while the patient's initial HFrEF was considered, quote unquote, I know it's hard to say, stable, she is hospitalized with acute decompensated heart failure 1 month later. All right? So again, the question comes down to is how could we have prevented this 1 month hospitalization? Again, was this something foreseeable? What were the maybe errors of omission or addition? And so with that, I really want to pick everyone's brain up here. But I am going to start with you, Dr. Albert, one of my favorite nurses. What would you have done in this case, honestly? What are your thoughts?
I think initially the Lasix was really important. The patient came in fluid overloaded. She was hypervolemic, and just being on the Lasix would have been enough to decrease her potassium level. But I think the error was that, you know, of the 2 potassium binders, SCZ is really able to be used both in acute and chronic hyperkalemia. Patramir is more in chronic hyperkalemia, mainly because of the onset of action. So because SCZ starts within 1 hour of reducing potassium and she's in the hospital, even though it exchanges sodium for potassium, and we know that could increase sodium in the bloodstream, I would have still gone that route just to get that quick decrease. So giving her the Lasix would have been important, and maybe starting on SCZ. And maybe instead of giving a TID because the patient was right there getting Lasix, just start it daily and let it slowly start to decrease the potassium. From a long-term standpoint, if she was really going to be likely to get into trouble, maybe I would have her go home on Patramir, just because Patramir is not really useful in acute. It just takes longer for that onset of action. The reason why, I mean, they both have a little bit of different properties. Patramir, as you saw, you have to have 3 to 4 hours of time around each side of the drugs. She's not on that many drugs, and they're BID or once a day, so there's no reason why there couldn't be a break in the middle of the day where the person can take Patramir and then still get their morning and evening or afternoon medications. So I think either one of the 2 potassium binders would have been a good solution, and then she could have gone home on her evidence-based therapy. Obviously, she's young, she's only in her 50s. The fact that she's having so much decompensation tells me she needs to be on her evidence-based therapies. And her ejection fraction, I think you said, went down to like 19% or something. Her eGFR, I think, was 30?
That's correct.
Okay, so with an eGFR of 30, there is good literature out there that says if you have an MRA, if you start an MRA when their eGFR is, 30 to 35, you should continue it even after their eGFR goes down below 30. There's a beautiful meta-analysis from the RAASi and the emphasis study that was published, I want to say, in 2025. And you could see an improvement or a decrease, a significant decrease in mortality, cardiovascular mortality, and hospitalization if you maintain somebody on the MRA even after the eGFR goes below 30. So that's something that we all need to keep in mind as we need to keep up with the literature. In this case, it was a meta-analysis from the 2 large studies. It wasn't a prospective study, but it was a really huge design, well-done studies, and I think it was important information for us to keep in mind.
Perfect. Awesome. One of the questions I'm going to ask the audience, because I'm interested myself, how many of you use chronic potassium binders within your patient populations? All right, you know what? That's Perfect, excellent. Because one of the things I wanted to get from my two fabulous physicians here who sit on guidelines. You know, the guidelines are not very clear on this. Now, they may change with the next iteration, but they're kind of a little silent on this. I would love to get your two, what are your opinions? What are your thoughts?
Yeah,
Like on chronic use. I mean, again, we don't have strong support. Guidelines are kind of, so thoughts.
Yeah, I think that these therapies, when used chronically, is attempting to provide an additional available option for clinicians to sort of lean in on. And while there may be various approaches that might be appropriate for that particular individual, that particular patient, having that discussion and saying this is a life-saving medicine, taking an additional pill might help you stay on this medicine. Patients may actually be able to be engaged in a shared decision-making process. But the guidelines, I think, are intentionally vague in not sort of implementing a very rigid structure that we must do X, Y, or Z in a pathway, because each individual patient's preferences are different and the responses to therapies are different.
Yeah, I think that's right. I think one of the, this is a wonderful case, but it also illustrates really acutely the problem, right? This is a patient who came in on a beautiful medical regimen and leaves on a patently suboptimal regimen, right? And I think has subsequent consequences of having withdrawn therapy. And I think there is the opportunity in this patient to think about, number one, this idea that mild elevations in potassium maybe are not things we have to overreact to. So a potassium of 5 or 5, maybe the 5-6, but the 5 is probably not a threshold that should motivate change in therapy, especially in somebody who's going to get loop diuretics and who's congested and has had a transient decline in renal function in the setting of congestion. We expect those patients to improve renal function. But the other general point about binders, I think, is that I think there's a lot of resistance. We have so many drugs in our that we're giving to patients. The idea of adding another drug to treat side effects of our other agents feels a little uncomfortable. But I think we have predicate for doing that in other spheres of medicine, right? We give chemotherapy, we give antiemetics in order to tolerate better the chemotherapy. So I think there is a rationale for doing this when we are confident that the patient is going to get benefit. I think part of the reason guidelines have not embraced routine use of these agents is that we don't really have outcome trials that suggest that in patients who, we know you can enable RAS inhibitor therapy a little bit better over short duration, but we don't know whether that strategy translates into long-term improvement in outcomes. We have reason to believe that might be true because we know that discontinuation is bad, but we don't really have a lot of outcome trials. And I think those would be helpful, particularly given this question of which agent and which patient and whether sodium exchange or calcium exchange is a better strategy. I just want to, because I do hope we'll get to it, I think this one issue that I think, Muthiah raised, that we have two different drugs here as binders, patiromer and SCC. And in REALIZE-K, which was the SCC trial, there was this signal of more edema and heart failure related events. And I think that's led people to say, gosh, can't use SCC in heart failure. I don't think that's accurate. I think we were part of that trial, and I think if you looked at the heart failure events in that trial, they almost all occurred in patients with very high levels of NT-proBNP at baseline. So generally, you're talking about the more congested heart failure patients who then developed some worsening events. This wasn't sort of new development of heart failure in patients who had no congestion at baseline. Right. And so I think the signal is there, but I think in general the message is probably decongest your patient first and then consider the binder. And then, as Nancy said, there are reasons to think that in some settings one might be preferred over another despite that. So I don't think there should be a routine concern in heart failure.
I'll just add, oftentimes when we see high potassium, the first thing we think about is, just tell our patients to stop eating, potassium-rich foods. But some people, I know we have done much less of this. We don't foster a really low sodium diet anymore. The guidelines do not encourage low sodium, really low, 2,000 milligrams a day. So patients should be eating regular diets and healthy foods, and you want them to get the fruits and vegetables and have more of that Mediterranean type diet. So by telling patients to just decrease potassium in their foods is really not the answer. I have many patients that used to eat 1 banana a day, and I asked them to stop, and their potassium was still high. So, and a couple days ago, you may remember I mentioned in my earlier talk that up to 39% or almost 40% of our patients are going to have chronic hyperkalemia once they get it. So we need to think of a better strategy than just assuming low diet or diet changes are going to be the answer. And because we have 2 options and they both work, for those of you who haven't used it, it's a powder. Patients have to mix it in 45 cc's of water and drink it quickly until it's gone. And if there's a little residue, they put a little more water in and drink it. It takes me about an extra 10 minutes of time when I'm in clinic to explain how to use the drug because it is a powder. It's simple, and really the amount of time I spend in clinic is really just looking at their whole list of drugs. Just last week I had somebody with 22 drugs, and so I had to go through each one because they weren't all heart failure related to make sure that we could find the best time so that on 2 hours on each side of the other drugs that they wouldn't be taking them, because it will, when it excretes it in the stool, it'll excrete your other drugs as well. So we want to make sure that the patient gets that bioavailability in the gut of the other drugs before this one is taken.
Excellent.
So it's
Excellent.
easy to use. Either drug is easy
Well,
to
I
use.
was going to want to ask the other question was regards to dietary modification, and I think you highlighted that as well, because that's one thing that comes up.
Yeah.
Yeah, with regards to that. So I promise you it's still too early in the morning, especially when a lot of people did karaoke last night. But nonetheless, wow, I've got a hard audience. Anyway, nonetheless, one of the things that I would like to highlight, because one of the things I do as a clinical pharmacist is provide my providers with excellent resources. And I want to direct you into this particular one from the Heart Failure Society of America. It's a clinical science statement that basically reviews some of the overview of hyperkalemia. And again, to keep in mind that it has to be individualized and the appropriate treatments mentioned. You can see here I just want you to focus in on that middle, that's just the middle area between 5 to, again, 5.9. And then again, in terms of considerations of either one, the dose reduction, and I want to highlight temporary, and then the consideration of a potassium binder after, rechecking our potassium. So with that, I do want to leave some time for questions. So with that, would you like me to read?
I'm happy.
Go right ahead. Okay.
So we have a lot of questions in a few minutes, so we're going to quickly kind of move through. And I'll open it up to the panel, whoever's would like to respond. So one question is related to, when you follow patients over time, there are often 2 major laboratory changes, potassium changes, but also kidney function changes. Mm-hmm. And so how do you disconnect this? Let's say a patient has worsening kidney function and hyperkalemia. You start a potassium binder perhaps to address the potassium issue, but still this worsening kidney function might continue to slide. And so how do you balance this, and how do you think about continuation or dosing changes of medical therapies in that patient with progressive kidney dysfunction?
I think that's a great question. So we need to all remember that even though somebody has deteriorating kidney function, and we see that very commonly, it's up to 35 to 50% of our patients with HFrEF, and it occurs in HFpEF as well, that we should try to keep our patients on evidence-based therapy. We know that when kidney function decreases, it doesn't always mean that the kidneys are damaged and we're having major changes. It may just be the response to the drug initially. And over time, we know that eGFR will decrease more slowly if we maintain our patients on our MRA and our RAASi therapies. Now, the beta blockers don't create that effect, so it's really those 2 drug groups that we have to worry about. SGLT2 inhibitor as well. In fact, the SGLT2 inhibitor studies have great figures in the literature showing that initial drop, it's very brief, it's very short, it goes down, and then we could see over time the curve spreading out, compared to the placebo group, which has this dramatic drop very quickly and very early on. So being on the right therapies is really important in our patients with chronic kidney disease that's getting worse.
Yeah, the only, I think that's spot on, and the only other thing I would just echo is the reference you made earlier to this observation that we also know that our thresholds for initiation and continuation based on renal function of guideline-directed medical therapy are different, and we have pretty compelling evidence that if you're on a drug and the EGFR dips, we don't necessarily need to withdraw the drug just because we've crossed that magic EGFR of 30 threshold. There's evidence that we can continue safely those agents. And then the other thing is just a pet peeve that I want to share, which is all of our medical house staff are fond of writing in the chart that the creatinine went up by 0.3 milligrams per deciliter. The patient has acute kidney injury. That is not acute kidney injury. That is a hemodynamic change in renal function. And in the case, the patient had a recovery or improvement in renal function just with diuretics, which kind of proves that point. So I think be mindful that small changes in renal function are anticipated with these agents. That often renal function is dynamic and related to congestion and may fluctuate, and just a small fluctuation in EGFR shouldn't prompt intensification or de-escalation of therapy.
And to your point, Dr. Desai, I always tell the residents, that means the drug's working. That means I'm having effects on the afferent and efferent arterial, right? And so therefore, we know we're heading in the right direction, even though it doesn't seem right?
Absolutely. Akshay, we have a follow-up question for you related to the provocative data you shared from the podcast trial that sort of suggested that we should be pushing the bounds of what is normal, reconsider what is normal for potassium levels. So how do you manage this in practice? What is a normal potassium level, and what makes your sort of what makes your eyebrows sort of rise if you get a page about a potassium level?
Yeah, I think that the nadir of risk, just from the epidemiologic studies, is probably a potassium of around 4.5, and that matches with, in podcasts, what the target potassium or the achieved potassium level was, around 4.3. So my sense is somewhere above 4 is where we would like to be with potassium in our heart failure population. And I think that's important because we sometimes are very permissive about hypokalemia in these patients, and I think if you think about ventricular arrhythmias, they're equally likely and maybe even more likely to happen in low EF patients when the potassium is low. I think on the high end, I generally tolerate potassiums comfortably up to 5.5. I think some of our kidney colleagues feel like we could go even a little more. I have a little more temerity about going above 5.5, so I'm shooting generally between, I'd say 4 and 5.5 as sort of an optimal potassium for patients.
Perfect. All righty, we're going to stay on time so that everyone can get some fabulous beach time. I really do want to thank my panel. It's always a pleasure to be with you guys. And so thank you so very much. And thank you for your participation this morning.